Good evening. I'm Jill Pfeiffer, the Vice President for Research at Brown University. Welcome to our program, Frontlines of the Opioid Crisis, co-sponsored by the American Academy of Arts and Sciences, one of the country's leading scholarly organizations. Tonight, you'll hear from some distinguished speakers and panelists about a national problem that is of great personal significance to many families, and about how our researchers in Brown's schools of medicine and public health are working to develop solutions. I'd like to tell you about the order of this evening's program. In a moment, I'll introduce Brown President Christina Paxson. After her remarks, I will introduce Rhode Island Senator Sheldon Whitehouse, and then introduce our keynote speaker and moderator, Michael Botticelli. After Dr. Botticelli's remarks, he'll have a conversation with 3 researchers from Brown and an important leader from the state government in Rhode Island. At the end of the discussion, there'll be a chance to ask some questions. Christina Paxson is the 19th president of Brown University. Now in her 7th year, President Paxson has accomplished a great deal. She continues to preside over Building on Distinction, Brown's 10-year strategic plan she launched in 2014 to guide Brown's commitment to addressing the defining challenges of the 21st century. President Paxson's passionate belief in the power of knowledge infuses her leadership. She has championed collaboration by identifying research partnerships and opportunities in biomed, public health, entrepreneurship, and other areas that advance the interests of Providence and Rhode Island. As a result, Brown Research has been instrumental in advancing initiatives that bolster the knowledge and innovation economy that is rising here. A respected economist and public health expert, President Paxson's career as a scholar coalesced around how economic insights can inform policies that improve the human condition. And as an accomplished researcher, she will tell you that data matters to her. Indeed, among the reasons why Brown's work on opioid research has been so compelling is the hope it offers in reducing the number of lives affected by opioid addiction. So please join me in welcoming Christina Paxson.
Thank you, Jill, and good evening, everybody. Welcome to Brown. On behalf of the university and the American Academy of Arts and Sciences, welcome to our very special symposium on the opioid crisis. I'm particularly pleased that we're co-hosting this with the Academy. The Academy of Arts and Sciences is one of the nation's oldest and most prominent learned societies and independent policy research centers. Last year, I was honored to have been named a fellow of the Academy, joining many Brown colleagues, including Jill Pfeiffer. And among the responsibilities of being a fellow is to invigorate public conversation on the issues of our times through symposia like this one. Now, this is the Academy's first event here at Brown. I hope that there will be many more in the years to come, and I want to thank the Academy for co-hosting with us. And my thanks to Jill and her staff in the Office of the Vice President for Research for organizing the event. Now, on to our topic for the evening. I think there are few issues out there that are as disturbing as the opioid crisis. We know that this is a national epidemic. We know that it's a national public health emergency. And it's become so pervasive that opioid deaths have soared while deaths from other leading causes such as cancer and heart disease have dropped. Last year, more than 72,000 Americans died from drug overdoses, a record driven in large part by the spike in opioid abuse and the use of fentanyl to lace heroin or cocaine. And opioids are seen as a major contributing factor to lowering life expectancy in the US in recent years, something that rarely happens in the history of countries. So research into opioid abuse is an urgent national priority. I think that's pretty clear from the data, as we all know. And against this very bleak national picture, Rhode Island has offered reasons for hope. And Brown has been a very willing and eager partner to make the change happen here. In 2017, opioid-related deaths in Rhode Island dropped by 4% year over year, which was the first significant decline in almost a decade. And the state continues to be widely recognized for generating innovative research and treatment plans that are helping to ease the crisis. And the hope is that what we do here can not only improve the lives and well-being of Rhode Islanders, but we can create models that help other parts of the country and spread out the knowledge that's created right here in Rhode Island. Dr. Nicole Alexander Scott, Director of the Rhode Island Department of Health and an alumnus of our School of Public Health, something we're very proud of, she is co-chair of the Prevent Overdose Rhode Island Task Force. And while she couldn't join us here this evening, she has been just a key player in addressing the opioid crisis in the state. We've been privileged to work with her on several issues and in several initiatives. Meanwhile, at Brown, we're doing what research universities do. We're focused on generating new discoveries and developing approaches to fight the opioid crisis. We always want our research, no matter what field it's in, to be consequential and to have an impact on today's important challenges. And our expansive work on opioid abuse, I think, fits right into this model of what the research mission of a university like Brown should be. Several Brown researchers, led by three that we'll hear from tonight, have been on the front lines of addressing the opioid crisis. Brandon Marshall, an epidemiologist at the School of Public Health, has been a national leader in the development of inexpensive test strips that help addicts avoid potentially fatal fentanyl poisoning. And his test findings were published just last week in the International Journal of Drug Policy. Tracy Greene, also in the School of Public Health, and Jody Rich at the Warren Alpert Medical School, have worked on designing and then documenting a program to treat state prison and inmates for drug addiction while in jail and then afterwards. And we know that release from prison is a time of very high risk of opioid death. And the program has been shown to dramatically reduce opioid deaths and is being studied around the country, and we'll hear more about that during our discussion. I would add that Professors Marshall, Rich, and Greene are all special advisors to the Prevent Overdose Rhode Island Task Force. Meanwhile, the Warren Alpert Medical School just won the 2018 AAMC Curricular Innovation Award from the Association of American Medical Colleges, an honor recognizing the opioid training that the school integrates into all 4 years of its medical curriculum. The future of research in this area at Brown and elsewhere in the world is very bright. Professor Rich was just elected to the National Academy of Medicine. Professor Greene will lead a new opioid research center at Rhode Island Hospital, backed by an $11.8 million NIH grant. And I'll note that Peter Monti, somebody who's worked in addiction for many, many years, alcohol and addiction, he's director of Brown Center for Alcohol and Addiction Studies. He would have been here this evening. He couldn't be for a very good reason. Today, he's receiving the prestigious Jack Mendelson Award from the National Institute on Alcohol Abuse and Alcoholism, and he's giving a lecture at the NIH, so that's why he's not here. So our symposium today comes at a very timely moment of promise. I think, despite this very grim backdrop, there are good things, promising things that are happening as we continue to find ways to address this very urgent health issue. So, I join all of you in looking forward to hearing from our keynote speaker, Michael Botticelli, our panelists, and as well as our senator. So thank you very much, and thanks for coming to this.
Thank you, President Paxson. Now I would like to introduce U.S. Senator Sheldon Whitehouse. Senator Whitehouse is in his second term as senator from Rhode Island. He has been a strong advocate in our state and nation in combating the opioid epidemic. In 2016, Senator Whitehouse worked with a bipartisan group of senators to pass the Comprehensive Addiction and Recovery Act, which helped create centers of excellence for the treatment of opioid use disorder. We appreciate his focus on this important national issue and we welcome here tonight.
Thank you, Dr. Pfeiffer. It's great to be here. I'm honored to be invited to speak at the first ever joint appearance of the American Academy of Arts and Sciences and Brown University. President Paxson, thank you for being here, and thank you for Brown's leadership in this space. The panel is wonderful. Director Boss will stand in for Director Alexander Scott, and they are both fabulous, so there's no loss of step as Dr. Alexander Scott recovers from her injury. Jody Rich has done wonderful work in this area, and we can congratulate him on being one of the newest members of the National Academy of Medicine. Doctors Greene and Marshall, thank you for your great work. I'm honored that Tom Coderre is here, who is leading this issue's response in the governor's office after having been the chief of staff to the SAMHSA director down in Washington. And he had a really important role in the Comprehensive Addiction Recovery Act as well. I would note also that my successor, my grand successor, I guess I should say, as United States Attorney, Steve Dambrook, is here as the acting United States Attorney, and I welcome Steve. And of course, the principal speaker, Michael Botticelli, is a hero of mine. He was the first director of the Office of National Drug Control Policy who was not out of either the military or law enforcement. And he was also the first who had the personal experience of being in recovery. And he brought a heart and a passion and a point of view to that office that made an enormous difference in our work, and he had a very significant role in CARA. As the opioid crisis began to emerge, some of us saw it coming. Rhode Island was a hard-hit state. Ohio was a very hard-hit state. So I worked with Senator Portman to try to build a bill that would be unstoppable through whatever hazards the partisanship in Congress might throw at it. It took some years to do all the work and to do all the building with all of the groups, but we ultimately did, and it was indeed unstoppable. Two experiences from that. First, we put money behind it. We got strong pledges to get the bill going forward that there would in fact be serious investment, and there has in fact been serious investment. And in Rhode Island, we're seeing probably $12 million more just this year, and we expect that to continue and increase. The second is that the way in which the bill was debated and the manner in which it passed and the broad bipartisan support for it all confirmed that a lot of the stigma that had been the dark shadow on this medical issue was abating. I'm not Pollyannish to think that it's completely gone. There still is stigma out there, but it is very, very significantly reduced. We did not have colleagues saying, this is a moral failing, these people need to be locked up and gotten off the streets, the only way to deal with this is with enforcement. None of that happened. People understood this was a medical issue, it does require treatment, and for that to work, you need research. And that's why this meeting is so important and why Brown's commitment to research is so important. A lot is happening in the treatment space with medication-assisted treatment and different ways to try to test how that works and different ways to try to see how the treatment should be delivered, and all of that is in a fairly nascent stage. But there's an even more nascent area that I want to mention, and that is the area of recovery. We have for a long time invested in prevention. We have for a long time invested in intervention. We have for a long time invested in overdose response. We've invested in treatment, and we've invested in inpatient care. But once you're through those phases, and once you go out to live a life in recovery, there's been very, very little support for that last important piece. For the first time, the recent funding focuses on that recovery piece, and that's been one of the important virtues of our last round of funding in Congress, but it also poses a challenge because the recovery piece has been so starved for resources for so long that we really haven't been able to build the evidentiary record yet. So in order to get things done in recovery, we will have to take some leaps of faith about what is likely to work and be bold in our thinking and our spending to reach into that recovery universe. But at the same time, we're also going to have to be very smart and very prudent about tracking what we do and making sure that that money is well spent and making sure that we can continue to fund it. I don't want to be in the situation we got into with the Affordable Care Act, where all the prevention money ended up being a political target. So at the same time, we have to be both bold and cautious, and I think the research work that's happening at Brown will position us to take advantage of that. It's my great honor to be here. I'm proud of our great university, and I'm particularly proud to share the stage with this terrific panel and with our principal speaker, Michael Botticelli. Thank you all so much.
So our next speaker, thank you, Senator Whitehouse. Our next speaker is a veteran of drug issues in America and one of the nation's leading voices about addiction. Michael Botticelli was in charge of national drug control policy under President Barack Obama. Currently, he is executive director of the Grayken Center for Addiction at Boston Medical Center. Before his service in Washington, he served for 9 years as director of the Bureau of Substance Abuse Services at the Massachusetts Department of Public Health. He will begin with some remarks and then lead our panel discussion. Welcome, Michael.
Good evening, everybody. It's a pleasure to be here this evening. I want to thank President Paxson for convening us to talk about what is perhaps the most pressing public health and social issue that we face today. Senator Whitehouse, it's great to see you again. I miss you tremendously, but thank you for your service and for being in Washington and to continue on the good fight on opioids and so many issues. I also like to thank the American Academy, and I have to give a shout out in a small world scenario to Dan Cuzzolino, who is now with the American Academy, who actually worked for us in the Office of National Drug Control Policy. So it's good that we now have champions and advocates in other high places. I also want to give a shout out to my colleague, Tom Coderre, who I've known for quite a long time. I am not the only high-serving person in the Obama administration that was in recovery. And Tom and I were often partners in crime for many of the things that we accomplished. And, I can't help but think, the last time we saw a health crisis like this was in the height of the HIV and AIDS epidemic. And there was an expression that those of us who were affected by this often used as it talked about the inclusion of people who were affected as part of the solutions to the problem. And that was nothing about us without us. And I think it's a clarion call for our work here today about how we involve affected communities, affected people, active drug users into the highest level of policymaking as we think about our work ahead. I jumped at the opportunity to moderate a panel by people who I have known and admired for a very long time, who have just been champions in this work and have really led the way, not only here in Rhode Island, but around the country in terms of the work that we're doing. So I thought I'd spend a little bit of time tonight just talking and framing my comments from kind of two standpoints. One is that the etiology and evolution of this epidemic has challenged us in every step along the way in terms of how this epidemic started, how it's evolved over time, and our ability to see around the corner in devising public health interventions and policies that meet the challenges. And then the second frame is to talk about the fact that this epidemic comes on the heels of some long historic deficits that we've had in terms of our attitudes to people with addiction, our public policy for people with addiction, and quite honestly, our treatment and intervention framework to do that. So I think all of you know, and President Paxson talked about the fact that in the early years, and still today, that we see the most significant morbidity and mortality attached to the vast overprescribing of prescription pain medication in the United States by our medical community. In 2012, at the peak of opioid prescribing, we were prescribing enough medication to give every adult American their own bottle of pain medication. And many perceived opioid prescribing as safe. They were told by pharmaceutical companies and doctors that it was non-addictive. It led to widespread diversion and misuse, with a quadrupling of overdose deaths linked to opioid-based pain medication. We had to devise ways to undo decades of medical training, often against the powerful sway of pharmaceutical companies and medical associations and practitioners who loathe government oversight and mandates. We needed to retrain people to dispose of unused and unwanted medications and to change regulations to allow for more ongoing drug disposal. While many communities and parts of the United States have long been impacted by opioids, and particularly those of us in New England, we saw many rural communities dramatically impacted, communities with little to no health infrastructure, let alone addiction treatment capacity. Many of us remember the expression hillbilly heroin that ascribed to the influx of opioid medications, particularly in rural areas like Appalachia and rural New England. This required us to devise strategies to develop and increase treatment capacity, often against the virulent opposition from those same communities that needed help the most. We saw the influx of very cheap, very pure heroin in parts of the country that historically saw very little of it. And because of the economics of drug use, this precipitated the transition of many addicted to pain medication to its cheaper and more powerful relative heroin. We saw and still see unprecedented levels of overdoses that require us to develop and expand new ways to reverse overdoses by everyone who is in a position to witness one. We had to speed development and approval of new naloxone delivery devices and convince law enforcement, first responders, that it was safe and effective to carry naloxone. We have also seen the emergence of very powerful illicit synthetic opioids, like fentanyl, that accelerated an overdose, leaving us very little time to intervene. And it required new public health communications and interventions and strategies to both detect these synthetics and to provide information, adequate information and appropriate information to drug users. I'm not an epidemiologist, but epidemics don't develop in a vacuum. Conditions must be ripe for epidemics to flourish, and it has laid bare long-standing challenges that we have faced. And I can't give a talk without this epidemic while first and foremost focusing on stigma. Stigma reflected in public attitudes, in clinical care, in the language that we use, in the media representation, in coverage and policy issues. A recent survey in Massachusetts done by Blue Cross Blue Shield Foundation in my good old home state of Massachusetts, that among survey respondents, while it's good that more than half of people believe that the opiate epidemic is a public health issue rather than a matter for law enforcement, only 1 in 4 people believe that addiction is a disease. 28% believe that addiction is a choice. 82% of people believe that people who are addicted to opioids bear all, most, or some of the blame for their addiction. And disturbingly, a lack of desire to give up their addiction is seen as the biggest barrier for people entering recovery. Those attitudes are borne out in our public policy, and my colleagues at the Johns Hopkins Bloomberg School of Public Health in a recent survey showed that when even compared to mental illness, people are more reluctant to want a treatment benefit for people with substance use disorders, that employers should be able to deny employment to people with a history of substance use disorders, and landlords should be able to deny housing. They went further to say that they would be unwilling to have a family member marry someone with a history of addiction or work closely with someone on the job. So these public attitudes, I think, most dramatically affected our approach federally to drug policy. My former office, I still have a hard time saying former office, Senator, was established by Congress in 1988 with 2 main functions. One, to set the current administration's drug policy, and second, to work with our federal agencies in making sure that the budget supported those drug policies. So if you look at the history of federal funding, that the largest percentage of funding until the end of the Obama administration focused largely on criminal justice and supply reduction approaches as it related to addiction. And that approach has led to the vast over-incarceration of people with substance use disorders, particularly people of color. And it's estimated that about 70% of our jails and prisons are there as a result of people who are there with addiction. We've had vast lack of insurance coverage, as well as equitable coverage of treatment by both public and private insurance companies. The Affordable Care Act actually required substance use disorder treatment as one of the 10 essential mandated health benefits for both Medicaid expansion and marketplace plans, leading to the dramatic expansion of treatment, particularly in those states that actually did expand Medicaid. We've had a significant lack of medical training on addiction. We have long considered the diagnosis, intervention, and treatment of addiction as an optional healthcare activity. According to the National Survey on Drug Use and Health, only a mere 15% of people who need treatment actually get it. And disturbingly, only 8% are those referred from our healthcare delivery system. The biggest referral source to treatment in the United States is our criminal justice system. We have also had a significant lack of attention to social determinants of health. The health of an individual is intertwined with the health of their community. And issues like poverty, racism, violence, early trauma, lack of educational and vocational opportunities, homelessness, and unstable housing often lead to these poor determinants of health. We will be back again in another 10 years if we don't address these social underlying causes that cause addiction and a wide variety of other health concerns. We've had lack of access to and support for the most highly effective treatment for people with opioid use disorders. So if I said to you, we have drugs that decrease mortality, that decrease infectious disease, that increase reduction in that decrease drug use, and increase quality of life, you would say, bring it on. But unfortunately, only 20% of those with an opioid use disorder actually get on a medication. Only 4% of primary care physicians in the United States have gone through the waiver training to be able to prescribe these medications, and only about 50% of those actually prescribe them at every level. At Boston Medical Center, we are now requiring every emergency room physician, every primary care provider, every family doc, every OB/GYN doc, and every psychiatrist to complete the waiver training by the end of this year. We have 60% of rural counties in the United States and 26% of urban counties that have no waivered physicians. And again, disturbingly, only 23% of publicly funded treatment programs and less than 50% of privately funded programs provide access to medications as part of their program. 50% of drug courts offer access to medications. And only one state, and I'm glad I'm in that state, Rhode Island, reported full access to all 3 forms of opioid addiction medications while incarcerated. 16 states only offer naltrexone, 1 medication, and the remaining 28 don't fully offer any medication to prisoners with opioid use disorders, despite rates of 120 times the overdose than in the general population. And a significant belief, stigma, that being on a medication is not fully in recovery. So, the final 2 points I want to make is that up until recently, we have lacked a widespread advocacy movement and visible recovery community in the United States. And again, I compare this to HIV/AIDS in the United States when politicians failed to utter the words, when we had a lack of appetite for resources for research and treatment. And it really fell to a bunch of angry gay men and lesbians to change that situation with the formation of ACT UP. Tom and I also have talked about the fact that the recovery movement needs an ACT UP to lobby our officials for more resources and treatment. But we've also seen a lack of support to reduce harm for those who still use. We still cling to age-old and unproven arguments that reducing harm only perpetuates drug use. So we see incredible lack of uptake for syringe service programs, and a flat denial by folks in our federal government that overdose prevention sites or safe injection facilities are, despite all of the data, are not worth part of our comprehensive response to this disease. So where does this all lead us? And I have a few thoughts on this, and then we'll invite our panelists up. So clearly we need better, faster, and more localized data to better evaluate the consequences of our actions and to monitor in real time changes in the patterns in this epidemic. I felt incredibly frustrated as a person in charge of federal drug policy to be looking at 2-year-old data as it related to this epidemic, and to only hear about fentanyl outbreaks in our communities when I saw it in the press. We need to require training and competencies for current and future medical practitioners to increase diagnosis, intervention, treatment of substance use disorders in our healthcare delivery system. We need widespread and dramatic expansion of community-based harm reduction and treatment services, particularly in highly impacted and underserved communities. We need more urgent uptake of medications for addiction in our treatment programs, in our courts, in our jails and prisons, and in our healthcare settings. We need to divert people away from our criminal justice system, providing evidence-based care for those currently incarcerated, and providing continuity of coverage for those transitioning back to community settings. We need to accelerate research and innovation. Our understanding of this disease is only new over the past several decades, and we need folks like our panelists to accelerate our understanding of what works. We need to continue to promote and support more widespread advocacy, creating a more visible and vocal recovery community. We need to focus on underlying social determinants of health. We need leadership, and fundamentally, we need resources. We can only do what we can do with so much, and this epidemic and the magnitude of the epidemic requires continued leadership and continued resources if we want to continue to make progress against this epidemic. So now I'd like to welcome up our panelists, and I'll have you come up on the stage. So first coming on, I'll see how good my order is Dr. Jody Rich, who's a professor of medicine and epidemiology at the Warren Alpert Medical School of Brown University. He's a leader on health issues for those who are incarcerated and is the director and co-director of the Center for Prisoner Health and Human Rights at Miriam Hospital. He is also co-founder of the Nationwide Center for AIDS Research Collaboration and HIV in Corrections Initiative. Wow, that was like perfect timing. I just have to say that we partially share Dr. Greene, who also works at the Injury Prevention Center at Boston Medical Center. So we're thrilled to have her here. So you guys, please sit down. Tracy Greene is an epidemiologist to my left, whose research focuses on drug use, opioid addiction, and drug-related injury. Currently, I know her well in her role as the Deputy Director at the Boston Medical Center Injury Prevention Center. She is also an adjunct professor at Brown, where she co-directs, along with Jody, the Center of Biomedical Research Excellence on Opioids and Overdose at Rhode Island Hospital. At the end, Brandon Marshall, who's an associate with many of my colleagues at Boston Medical Center. He is an associate professor of epidemiology at Brown School of Public Health. His research focuses on substance use epidemiology and infectious disease. He's the scientific director of Prevent Overdose Rhode Island, Rhode Island's drug overdose information dashboard. He worked closely with the Department of Health to track, measure, and evaluate preventive efforts. Just last week, he published another major paper about the use of fentanyl test strips to reduce harm to drug users. I think I tweeted out your study, Brandon. And then we're thrilled to have a longtime friend and colleague, Rebecca Boss, who is the co-chair of Prevent Rhode Island Task Force. She has been director of the Rhode Island Department of Behavioral Health Care, Developmental Disabilities in Hospitals since May of 2017, after serving a long acting director role for 10 months. Many of us were glad to see her in that role permanently. She has more than 20 years of experience in addiction treatment field and as a clinical supervisor and a program director. So let's welcome them all here. So I want to pick up on a theme that President Paxson said, and that we are beginning to see Rhode Island and other states for a very long time, we saw this trajectory, upward trajectory with no end in sight. And we're seeing Rhode Island and some other states, particularly Massachusetts and Vermont and New England, that despite significant presence of fentanyl, they're making some tentative progress in reducing opioid mortality here. So I want you to think about, kind of from your perspective, what do you think are the essential ingredients that went into Rhode Island's success and other states' success that we can use to replicate and amplify with other states who are still struggling with dramatic year-on-year increases? So Tracy, you want to start?
Sure. Well, I think we all have a lot to say on this one. There's been a huge effort in the state from the get-go to work partnered with community members, partnered with coalitions, working in recovery, working in harm reduction, working in public health, working in law enforcement. And this particular topic early on had brought many voices to the table in ways that other health topics or other pernicious problems really hadn't. So Rhode Island did have a strong community base to begin with. And that also partnered a lot with researchers like myself and Dr. Marshall and Dr. Rich. And many others who identified this particular problem, that is opioid addiction and opioid overdose, as an area that needed research. And so that was a huge component, I think, to what some of the work that we've been doing. And I'll let others add to that.
So I think I'll add that, unfortunately, opioid use is not new in Rhode Island, as you know, from our long-standing history in New England, with having an opioid issue here prior to the epidemic that the rest of the country faced. And so we have a little bit of history, and we had a good foundation of evidence-based treatment and medication-assisted treatment here in Rhode Island that didn't exist elsewhere. But really, the leadership of the governor in forming the task force and bringing together a diverse population of people to really lead the effort in engaging the expert advisors and developing a plan for us to move forward and then acting on that plan was really key to us, I think, bending that curve and finally getting to the point where we saw the decrease with really strategic efforts in the 4 key areas. And you know, I've talked nationally about the innovation that Rhode Island has demonstrated in addressing this epidemic, and you need to be flexible. As the epidemic has changed, we need to change our approach. And I believe we demonstrate that flexibility in this state in changing our approach and recognizing what works and what isn't working, and really trying to make sure that we are devoting our efforts in those that have the most significant impact.
I would certainly echo the leadership as one of the components that you called for. The governor has certainly been very helpful with that. It's hard to think of this as a success when we have hundreds of people dying every day, and people who are not dying, and that the deaths are just really the tip of the iceberg. So, you know, part of this is that so many of us have been impacted. It's hard to find a family that hasn't been impacted in this state. So I think that has helped to wake people up to that we need a different approach.
Yeah, I think 2 things to draw on that point around leadership. I've been so inspired and impressed by the leadership we have in Rhode Island to listen to people that are most affected by the crisis, to engage with communities, reach out to researchers, and develop a plan that is evidence-based and impactful. So that's the first thing I've seen. And the second thing really gets to the title of this session, Frontlines on the Opioid Crisis. One of the favorite parts about my job is learning and watching the tremendous work done by people who are truly on the front line, working every day to provide life-saving services to people. People like Jonathan, who leads some of our street outreach services, people like Colleen and Ray, who provide harm reduction programming that really does save lives across the state. They're the ones on the front lines, and I think they're doing tremendous work, and I feel very fortunate in my role as a researcher to support some of those efforts and to provide the evidence around the effectiveness of these approaches.
Great. I wonder, you know, particularly for the researchers on our panel, you know, it must be, I don't want to kind of lead the witness here, but it must be incredibly frustrating as researchers to see evidence-based strategies that you're producing and promoting. Yet often there is such a significant lag time between our findings of those research studies and practice and policies. And Becky and I have been kind of those policymakers, and I'm sure your frustration at us, in essence, for kind of failure to move with a sense of urgency. So what maybe you could kind of talk about? Well, are there things? What are the levels of frustration or barriers that you've encountered with the system, if you will, around implementing kind of all of those things that we know to be effective, as well as kind of emerging studies that have come out as it relates to fentanyl test strips or providing people who are incarcerated with all 3 FDA-approved medications. So maybe you can give us your perspective as researchers about what are some of the challenges that you've seen from the research side in terms of implementing those programs and policies.
So I think in addition to getting a PhD, I should have gotten an MBA, a public policy degree, and probably some wings on the lobbying end. But these are things you learn along the way. And importantly, I think Rhode Island is a wonderful place to conduct research, to partner with policymakers, to understand the limits of our laws and where our laws are silent and where they may need more structure, where science can help give guidance, and we can have the kind of synergies that have brought us here today. So taking an idea or a pilot idea of providing medications for addiction treatment behind the walls can be a randomized controlled trial or a pilot, but then we can look to the future and say, how could this be implemented and work in partnership with the institutions as well as with the lawmakers and the fiscal agents to make it all really a reality. But the opportunity that I think Brown has in particular is to build those to tear down those walls and remove the silos and allow research to really speak and rise above and allow the evidence-based interventions to really lead. And that's the amazing thing about the strategic plan efforts, was to have the science be listened to.
Great, good. Jody?
So I think it's worth looking back to the governor's task force and that process. And preceding that, I had spent decades about working with this population, studying this population, trying to build up the evidence base to show that these medications are effective in these high-risk populations. And I kind of naively thought that if I just show the evidence that the policy is going to change. And I had this epiphany in 2015 when I realized all this work, millions of federal research dollars, published papers in prominent journals, having a great career, hadn't done anything. I hadn't budged the dial. I hadn't really changed the policy. And I want to give a shout out to Josh Sharfstein from currently at Hopkins School of Public Health, who has been advising us and giving us sage advice, and sort of suggested some of the components of the strategy. But it was really in partnership with the governor, with the directors, with the task force chairs, that we were able to turn things around. Now, some of that was the stars aligning, that the epidemic had reached a certain level, but some of it was just realizing that the research is not enough. Building up the evidence is not enough. You need to be able to actually advocate and fight for that to be implemented. And so I think that is an obligation for us as researchers. Just as a physician, if you make a diagnosis and you write a prescription, if the patient doesn't have the insurance to fill that or the ability to get to where they need to get it, you haven't done anything. So you have to kind of take a step back and look at how you're going to have an impact.
Great.
And that's really need to incorporate that into the research.
Good. Brandon?
Yeah, I think one of the biggest barriers I see to the adoption of research into practice is what you mentioned, Michael, in your keynote, the ongoing stigma and stereotyping of people who use drugs as not wanting to change not wanting help, this false idea that they don't want treatment, that they can't be in control of their health or take steps to improve their health. Those false stereotypes, I think, prevent implementation of a lot of research, a lot of interventions that we know works. And so I think as researchers, we need to advocate for programs that we know work and be very clear that when they're implemented appropriately and to scale, people do present, and they benefit tremendously from interventions such as treatment that we know are so effective.
So let me kind of segue off of what you just said, and that stigma, and I believe, at least from my standpoint, that you're correct, that stigma has manifested itself in many different ways, and one of those ways is a lack of urgency, if you will, to kind of implement the work that we know to have happened. So if you were to be able to kind of change one thing as it relates to public attitudes or public policy for people who suffer from substance use disorders, what do you think that would be? And I'll start with Becky, since I let you off the hook on the last question.
That's fine. So my answer is very easy for me. It's the negative public attitudes on medication-assisted treatment. So not only do we have a condition that is stigmatized, but we also have a treatment that's stigmatized. And I can give you so many examples of times when different communities, whether it's the recovery community, the medical community, the treatment community, I have heard messages where people don't believe that medication-assisted treatment is recovery and will stigmatize individuals on medication-assisted treatment, and then that keeps people from engaging. And if we could really change one thing, it, for me, would be the attitudes around the use of medication in the treatment of addiction.
So I'm going to kind of expand on that. I think related to the stigma has been this sort of unfortunate history of the war on drugs, which we heard has been our major investment in dealing with addiction in this country, continues to be, in spite of the senator's help. But that is the key problem, and that has a sordid and unfortunate history and racist history. But I think that, and I think the stigma is part of that. But what we showed in Rhode Island is that if we expanded treatment into the correctional system, that we dropped overdose deaths dramatically. And we need to continue along that trajectory. We need to continue to expand treatment, these effective medication treatments, and expand recovery services. And so right now, we have police, and we're giving them direction, say, go and find people who have these drugs, who are using these drugs, and arrest them and bring them to the criminal justice system. That is not helpful. That is often harmful. Sometimes people are so crazed they need to just be removed from their environment for their own safety. But most of the time, it's extremely detrimental. And I say that having been behind bars this morning and just about every other Tuesday for the last quarter of a century. What I think we need to do is have a fundamental change in there. We need to have, instead of bringing them into the criminal justice system, bring them into treatment. So how do we get them into treatment? Well, that's actually been tried in Portugal. Now, we're not Portugal, although we have a lot of people from Portugal here in Rhode Island. 18 years ago, they had the worst drug problem in all of Europe. They had the highest rates of incarceration related to drugs. They had the highest rate of injection drug use related to HIV. And they had the highest rate of overdose in all of Europe. And they did something radical. They removed criminal penalties for possession and use of drugs. It's still illegal to sell drugs. And they expanded treatment. They still coerced people to get into treatment, but not into the criminal justice system. So the criminal justice system got a lot less people into it. The injection drug use related to HIV dropped. overdose dropped. So now, on those 3 measures, they're about the best in all of Europe. Went from the worst to the best. And overall drug use has gone down. So if we talk about, well, we want to decriminalize syringes, first of all, if you say that, you're going to alienate a lot of people because they think that's wrong. And there's this notion that we're holding the dam, like this is such a problem, we have to hold the line here, we have to keep these criminal penalties. But in fact, we're not holding anything. We're making things worse. When you think about an individual who died of an overdose, and you look at that situation around that individual and the community and all the social determinants of health, that individual in this state didn't die because we didn't have enough arrests, because we didn't have enough incarceration, because we didn't have enough, police presence. That individual probably may have died because we had too much of that and not enough treatment. So right now, we have a governor who is interested in evidence-based approaches, and she's proven that in this first term. We are about to have an attorney general who understands these issues, who's compassionate, who's committed. And we have a state that's small. So to convince maybe 10,000, 20,000 people that an approach where you expand treatment instead of criminal justice, we divert people out of criminal justice and expand treatment, is really going to make a fundamental change in this epidemic, is what we need. And if we do that in Rhode Island, just as we showed that treatment in corrections leads to dramatic positive changes, we're getting calls from almost every state. How did you do it? How can we do it? What led to it? And I think we can continue to lead the nation if we push in that direction.
Great. Brandon and Tracy, I want to ask you this question because I think some of that stigma really manifests itself in our historic approach to lack of urgency around harm reduction approaches, right? That somehow providing people with access to sterile syringes or safe places to inject drugs, this is an age-old argument, this is what I was talking about, that despite all the evidence to show that it's not true and that actually things work, and there are places in other parts of the country that have done these successfully, we still have, I think, significant pushback, and even pushback, quite honestly, along the political spectrum here around that. Much of that tied to stigma, that kind of active drug users don't deserve things like to not have infectious disease and to not overdose and die. What kind of one thing or two things would you suggest to begin to change people's attitudes that kind of those kinds of harm reduction approaches really kind of deserve a place in our community and in our public policy?
Do you want to start? Well, I think that part of that is an onus on the research community within harm reduction researchers to be really explicit and to work hard to amass the kind of data that can be persuasive, much like other elements of our approaches, treatment, recovery, and to make sure that we catalog and document the kinds of effect and the kinds of connections that repeated exposure to any positive change, whether it's a syringe exchange program or otherwise, may then eventually lead to treatment for their hepatitis C or treatment for their HIV or connections for buprenorphine or other outcomes that clinically we determine are important, and to catalog and understand that. So part of that, I think, is that we need data and we need investments in data and research to allow us to be able to say positive and important things. And that often is not going to come from the federal government. Mm-hmm. So the onus is on our institutions and our private partners, private fellowships and otherwise, to make sure that we have investments in these harm reduction areas to make it possible for the data to be heard. So that's one thing, and I think the other piece is, importantly, we have, as the opportunity to build pilot projects into and normalize harm reduction, for instance, into our experiences in the prisons and jails, into the primary cares, and to the hospitals. And these environments that we've already determined are important institutions for society can all adopt harm reduction principles, can all adopt harm reduction materials and approaches to care. And so the idea of normalizing and systematizing harm reduction is eventually the way that we can reduce stigma in the long run and build out also a healthier policy that begins where people are instead of expecting them in a system that may not have even ever been thinking about them to begin with.
Yeah, I think we could do better, researchers, and many of us working in this area could do better at communicating why harm reduction works. And I think to do that, we can start with what we know doesn't work. What doesn't work is pushing people out on the street, applying punitive measures, incarcerating folks. This idea that people need to hit rock bottom before they're willing to engage in any kind of treatment is an incredibly harmful false narrative that still pervades much of what we see in media and in our broader society. So I see harm reduction as the opposite of that. Programs such as providing sterile syringes, such as supervised consumption spaces, allow for us to connect with people who use drugs, to engage with folks, to build rapport, and through that more helpful and supportive mechanism, we can perhaps eventually get someone on the pathway to treatment and recovery. And that might not be tomorrow, that might not be a week from now, that might not be a month from now, but I always say that, treatment doesn't work if the person is dead. They have to be alive to engage with it. So harm reduction programs allow for that engagement until we get to that point, and foster that sense of community and connection that's so critical.
Good.
So I spent almost an hour today talking to a parent of a young person I met this morning for the first time at the Department of Corrections, who had suffered with opioid use disorder for about half their life and had been locked up for several years and was eager to get out and get to work, and the family was going to be supportive, and but didn't want medicines. And my family doesn't want me to be on medicines. And, why would I start that? And I'm just going to get on with my life. And I said, well, that could work. You haven't been using since you've been locked up, and you might. But the data shows that you probably have about a 90% chance of relapsing. And 3 years ago, the stuff that he had already overdosed on is going to be a lot worse. So we had a long talk about that. And then I asked for permission to talk to the parent and said, okay, what are you going to tell my parent? His plan was to get out and try not to use, and that if that was plan A, and if they developed cravings or urges or was going to get into some kind of counseling, and if that didn't work, to get onto treatment with medications. And then I talked to the parent, who said, well, I'm going to support him, and we're going to get him a job, and you can stay in the house, and we really want him to succeed, and we want this, but I've got a zero tolerance policy. The first sign of any use, that's it. He's going to get fired from his job, he's out of the house, he's going to get kicked off. And I said, well, is that really what you want? Because that zero tolerance policy is great if it works, but that's not really what you want. For this young person, I want the same thing. We all want the same thing. We want him not to overdose and die. We want him to live his life. We want him not to be tortured by this addiction. And so if he's got a 90% chance of relapsing, and you as a parent have to, by doing a zero tolerance policy, that's probably not going to work out well, and that's probably not what you want. What you really want is him to be alive and healthy. So that's, and I was talking about the goals in a harm reduction fashion. Like, that we have these medications that work, and that if he goes in that direction, be tough on him and kick him out. Is, this kid has been locked up for a long time in some tough places. That, tough love is not really working. So why don't we try something that actually might work?
Great. Becky, I want to ask you a question. We've both been doing this work for a very long time, as long as folks on the panel, and I think we've seen, despite all of the scientific evidence that treatment works, that it doesn't increase drug use or crime in our communities, we've seen even today still significant pushback from many of our communities when we talk about expanding treatment, particularly in those neighborhoods. So how do we get at some of these issues of the kind of NIMBY, not in my backyard phenomena? What have you seen in terms of successful approaches and community engagement? Because that kind of stigma exists at multiple levels, and certainly at the community level, it's really been a challenge, I think, to have communities understand that treatment is important and actually decreases crime. So how do we work with community members to really embrace treatment in their communities?
That's a really timely question, given that issue came up today and this week, and everyone wants treatment for individuals. I just don't want it here. I want it somewhere else. I don't want it in my neighborhood. I want it to be over there, so other people have it in their neighborhood. It still exists, and we combat it. And one of the most successful strategies I've seen was one of our opioid treatment programs went to be in downtown Newport, Rhode Island, tourist attraction, Newport, Rhode Island. They did a lot of work up front with the community, with law enforcement, with first responders, with the business folks, before they even opened, to establish those relationships and made them feel that they would be responsive to any issues that arose as a result of this treatment program being in Newport. We still have that issue today. There are treatment programs that are coming up. We encourage our providers, get out in the community, work with the people who are in the community, be a partner, and you have to be a partner. So that's probably the first thing. The other thing is that we've talked about the ACT UP of the recovery community that's needed. We need individuals in recovery who are willing to be out there to say, recovery works, here I am, I'm a part of the solution. And we don't want to believe that addiction is in our neighborhood. Addiction's in our neighborhood, right? So we know that there are people that are living next to us, or down the road, or in the same building, that have active substance use disorders. I would rather have a treatment program next door than have people who are actively using substances next door, and treatment programs are going to help address that problem. So it's that conversation you need to engage in, but you have to engage your partners. That's one of the things that I think Rhode Island has done so well, and I see Captain Moynihan here from the Rhode Island State Police. I saw Captain Zach Kenyon from the Providence Fire Department. We've engaged labor in our discussions. We have labor's unions involved in the task force. These are the partners that we need to help share the message, because I can say it all day long, but when I have mothers like I see here in the audience and others who are helping me carry that message out, then it's other people speaking and not just me. So it's really based on partnerships. It's those relationships that are so critical.
Great. So I want to pick up on that theme of who do we partner with. Tracy, you talked a little bit about it as kind of researchers. Who do we have to partner with to kind of get our message out? And I look back and think about naloxone distribution by first responders, that it was really other police officers, and quite honestly, it was the police officer from Quincy, Massachusetts, who went around the country and convinced other police officers about the merits of carrying naloxone, and now we just see that widespread attention. So if we think about this from a research perspective or even a practice perspective, who are unexpected messengers in this work that we really think, if we can't get the message out through science and data, and have to rely on parents and first responders, who do you think who should we be partnering with to help us kind of amplify and promote the messages that we want to get out? And I'll just, for anyone who wants to respond to that.
Well, I will say, so I was just yesterday in Toronto at the Law Enforcement and Public Health International Conference with the CDC and the High Intensity Drug Trafficking Area, a partnership that actually flourished under your direction, really focusing on partnerships between public health and public safety, and thinking that the current crisis and the emerging heroin and now more broadly fentanyl crisis is one that requires different partnerships than we had in the prescription opioid epidemic. And more broadly, public safety, incorporating fire and EMS and all of our volunteer services as well as police, really makes it possible to have a lot more room, a lot more voices at the table, and a lot more partnership for naloxone, for medications for addiction treatment, and for harm reduction services in addition. So that's been a really exciting partnership. The other group that I'd have to say has been really vibrant in Rhode Island is the Pharmacists, and they have been wonderful partners for getting syringe access with Dr. Rich, and early on the Pharmacy Board at the Department of Health, as well as the Pharmacists Association. And then now, just as of the end of August, we have a collaborative pharmacy practice agreement for medications for addiction treatment to offer, in a small study we're beginning this, but to offer buprenorphine in particular in a pharmacy-based environment. So addiction care could come to a pharmacy near you instead of being specifically at a clinic or at a particular treatment program. So this expands, complements, and expands the voices at the table and allows our continued message that to normalize treatment access and normalize harm reduction services more consistently. So those are new partners.
Yeah, I think something to your point, Michael, looking back at ACT UP, right? The power of that voice and how we, and myself included, really could do better at engaging with people who are using drugs and people in recovery. They're the true voice of this epidemic, and they're such a powerful ally in bringing the results of the research to tables and say, this is what I demand, this is what I deserve, because it will improve my health. And we saw that be such a potent force in the HIV epidemic, and I think we can see that here as well, is those kind of partnerships coming together and using the scientific evidence that folks like us generate to advocate for social change.
I've often said this before. There's a wonderful documentary called How to Survive a Plague. And if you haven't seen it, I really encourage you to look at it. They found archival footage of early meetings of ACT UP and the Treatment Advisory Group. And for all of us who are doing addiction work, I think the analogies are just completely transparent in terms of the work. But I'd really encourage you to do it, because I think the applicability of kind of what happened around HIV and AIDS and kind of what happened is really appropriate for kind of our current epidemic as we think about highly stigmatized disease, highly stigmatized people, kind of a historic kind of lack of kind of government response to this issue.
And thinking about unexpected messengers, thinking about the family members and parents who people have died or haven't died. But this is a family disease. It impacts everybody. And just last week, there was I guess it was a Facebook message about a young woman died in Vermont. And then there was a reply by the police chief, which is just
Yes.
very
Chief Del Pozo.
Chief Del Pozo. We should probably link to that. I think everybody watching this should read those.
Yep. Along with our some of the folks in this room and our colleagues at the Johns Hopkins Bloomberg Public Health, we sat down with a number of police officers, both locally and federally, and devised kind of 10 principles of care for police officers as part of their response to this epidemic. And Tracy, to your point, I think that they've been really kind of unexpected champions around a lot of the work that those of us in the public health field, quite honestly, are surprised that we've seen. And I think the more that we can, both from a research and innovation perspective, but also from a partnership perspective, to be able to kind of link to public safety folks in ways that those of us in the public health world used to kind of run away from, quite honestly.
Can I just add that there's no wrong partner? any partner in this discussion is the right partner, and I echo Jody's sentiment that families, the power of families cannot be understated. You look at the movement of the MAD, Mothers Against Drug Driving, and the influence that had. We have mothers that are getting angry, and angry mothers can really move mountains sometimes. I would say the recovery community has been a tremendous partner in Rhode Island. I look at Jonathan and the efforts that he's done. Brandon talks about going to outreach to people who are using on the street. Well, he's doing that on a daily basis and handing out Narcan, and we've got a lot of champions in the recovery community that are really doing amazing work in Rhode Island. And there are other partners, and I think about the faith community. Mm-hmm. How have we engaged the faith community? We had a prevention coalition work with a Catholic parish in, I think it was Portsmouth or Rhode Island, and they talked about how difficult it was to get parents engaged in the discussion about drug use in youth. And the priest stepped up and said, I have a captive audience. If they want to get through whatever it is that the adolescents go through, the parents had to attend, and he brought in the Prevention Coalition, and they had messages around substance use. And so there's clear partners, and then there's kind of the off the path partners that we need. There is no wrong partner.
Great. I just want to make one statement, and then we'll open it up to people in the audience to get a chance to talk. One of the things I hope you noticed is the strategic language choices that people on our panel are making, whether it's medications for addiction treatment, not medication-assisted treatment, people with substance use disorders or substance use disorders. And this is not just about being politically correct. That one of the things that we've found is the use of stigmatizing language when it relates to addiction, calling people clean as opposed to people in recovery. When we talk about someone with a substance abuse problem, researchers at the Recovery Research Institute found that it elicits a punitive response as opposed to a therapeutic response when you refer to someone as a person with a substance use disorder. So part of our work, I think all of our collective work in reframing addiction and reframing the stigma is reframing language, not calling people junkies and addicts, I think is really important to changing public perception. So I hope you've picked up on kind of the use of non-stigmatizing, clinically appropriate language that our panelists have been using. So with that, we have 2 microphones here. Just ask folks to come up to the microphone and kind of ask their question. And if you have it kind of directed toward a person, ask you to direct your question or to the panel in general. Good. So right here, you first.
Cindy McLeod, I'm a nurse working in the HIV and addiction field. Is there a realistic hope of treatment on demand? Within that context, could you comment on the deficit of treatment providers in the state, throughout the state, not just in Providence?
So I'll take that.
I think you get that one, Becky.
Yeah. We just had this discussion actually today about treatment on demand and what it means. And treatment on demand for us means that when an individual says, yes, I want treatment, that we have the capacity within the system to provide that treatment. So, I guess it depends upon what you are looking for. If treatment equates to beds, and inpatient detoxification or, residential treatment beds, we will probably never have enough capacity for that kind of treatment on demand. But we are actually moving in Rhode Island to create a new program that will be opening in November called BH Link, which is a 24/7 crisis response center where people can go, be treated, be assessed, be initiated treatment, and handed off to the next appropriate level of care, which may or may not involve a bed, but will definitely involve a clinical assessment for the right level of care. So we are so close to treatment on demand, though I will openly admit we will never have enough inpatient capacity if that's what we are equating to the need.
And will that address drugs like methamphetamines, cocaine, in addition to opiates?
So the BH Link will absolutely address all substances, so and mental health crisis as well. So somebody who may be normally referred to an emergency department or may be involved in the criminal justice system because of the fact that they've committed a crime, and they can be diverted to this 24/7 site for any type of substance involved or mental health involved crisis, be assessed and be connected to a level of care. Now, Medication used for treatment is not in methamphetamine and other stimulants. There's not effective treatment right now using medications. So more often inpatient treatment is appropriate. That will be an issue. So we do need to work on our capacity, although I'm never sure, like I said, I openly will admit that we probably won't have the capacity to meet every inpatient need.
I'm going to add on to what Becky said. That, I work at a large safety net hospital just up the road, and I think our healthcare infrastructure has been dramatically underutilized in terms of both the diagnosis and treatment of people with substance use disorders. And I think we have an extraordinary opportunity to think about, and we know, quite honestly, that the level of emergency department and inpatient utilization as a result of this epidemic. And I quite honestly think that hospitals and our primary care delivery sites have been dramatically underutilized. We've carved out treatment to a specialty treatment system and pretended like it's not part of healthcare. And I actually think it's time for our primary care and our other healthcare delivery sites to play a much more substantial role in treating people with addiction. It goes back to my saying we don't tell physicians, diabetes is probably the most prevalent disease condition you're gonna face, but don't worry, you really don't have to treat it. And so I do think that we've got to kind of create an understanding and, quite honestly, a mandate within our healthcare delivery systems that treating addiction is not an optional healthcare activity anymore.
Yeah, right now it's don't ask, don't tell.
Yeah.
Nor is it an optional benefit. And so the other piece to this is that we need to enforce parity.
Good.
Thank you all for coming today. I just have a question. Over the summer, I worked for a pain specialist, and he really showed no compassion for a lot of his patients. He would kind of walk out of the room and blatantly tell me, oh, like, this one's addicted. We're probably going to kick him out, or whatever. This happened a lot. And then it was startling because it was the largest pain management practice in all of Louisiana. And the next physician over would be the exact opposite, kind of counseling his patients on, like, substance abuse disorders and what they would be, what risk they would be taking on if they started treatment. And it was just, I know you can't really, it's hard to counsel or to train physicians into, like, compassionate care, but what are some of the approaches that you all would recommend when it comes to pushing physicians to kind of implement science-based solutions, especially, like, in states where there's a lot of stigma, and, like, I mean, Senator Whitehouse probably knows that Louisianan politicians are kind of not too active on the healthcare side of things. So it presents, like, a really unique challenge in trying to get physicians to implement these in a regulation kind of free state, especially when you can't really, it's a lot harder to kind of get them to care.
That would make good use of the criminal justice system, just to lock them all up. I think we've worked hard to try, you heard 96% of physicians don't have a data waiver, don't have the ability to prescribe, and of the half of the 4% that do, they're able to, but they don't. And one other statistic is that the half that actually do, almost half of them have only one or two patients. So we're really not, as a field, as a profession, stepping up to the plate to address this epidemic. Now, I had they roll me out to talk to the intern applicants, and usually talk about international work. And I always, as I start talking about working internationally, usually about a third of this group of 20 to 30 young people, you can see their eyes light up. It's like, yeah, I want to do that. So I was talking to one of them afterwards, and he said, I've been interviewing around the country, and he was in a Seattle program where they actually trained the medical students how to get a data waiver and how to prescribe buprenorphine. And he said, I went to some programs and I asked them, do you have that? And they said, oh, well, not really, but we're trying to, we want to. And in other programs he asked, and they said, what would you want to do that for? Why would you want to take care of those patients? That's kind of a prevailing attitude. And then, so the next week I got rolled out again to talk to a fresh group, and I told them that story, and I said, well, how many of you, might be interested in learning how to address this, number one health and medical and social and a public health problem that's, and they all, so that, the kids coming through get it, and we need to harness this as quickly as possible. We need to get them trained. Now the problem is they go to medical school and their professors don't really know, because we've all been trained in the era where we didn't deal with that. That's over there on the other side of the tracks in those dirty methadone programs, and it hasn't been incorporated in medicine. So we really need to do it. And I think there are some doctors that are, that get it, but I would say most don't. They never trained in this. They don't, they have a certain way of addressing addiction, and usually it's get the hell out of my office. So I think, the hope is the new generation coming through. Now, the other challenge is when they come to residency training. I love what's going on in Boston Medical Center, but that's what we need. And the problem is we don't have the staff that know how to do it, so they have to learn in parallel. But the medical students, we've had physicians, academic physicians come and do the training. They say, why are you doing the training? They say, well, because I'm getting shamed into it, because the medical students are asking me about this treatment, and the interns are asking me, like, why aren't you giving this evidence-based treatment? Yeah. And so they realize they have to catch up.
Yeah. I think that's a great example of advocacy, right? Because I think we saw the same thing here, same thing in Massachusetts, where medical students were actually lobbying their deans, saying, you're not giving us enough medical education. And I think Brown, along with schools in Massachusetts, have now implemented core competencies as part of their medical training. I think we are seeing a new generation of clinicians. I think part of the challenge is how do we train up the folks who are already doing the work, and not just docs, but nurses as well. And I think the level of stigma, our medical community are reflections of kind of our general societal attitudes around those issues. And so I do think that we're beginning to see that kind of change in training and change in philosophy.
Hi, my name is Peter. I'm in the Masters of Public Affairs program here at Brown. I'm appreciating the saliency of the HIV epidemic and applying that in some context to this. Unfortunately, one of the things I'm learning from that is there is a failure at the federal level. But I also see, in terms of identifying this as a crisis, crisis in advocacy in a crisis mode, and innovation in a crisis mode might be different than a long-term strategy. For instance, with HIV, we see it spreading to parts of the American South that, it used to be a San Francisco, New York issue 30 years ago, and now it's still continuing. It's not gone anywhere. So looking beyond 10 years, 20 years, 30 years, what does advocacy and innovation look like when it's not the urgency of a crisis, but it's the ongoing maintenance of prevention and of maintaining lower or reducing the impact of that crisis?
So we've just recently had that discussion around the refresh of our strategic plan for the Governor's Overdose Task Force. And we had, as was mentioned, 4 pillars of the task force plan. So that was treatment, rescue, prevention, and recovery. So our focus was saving lives. And just like in the HIV crisis, our focus still is on saving lives. We really focused a lot on the rescue and on the treatment pillars, but now we know that we need to go to the outer edges, really, to have a long-lasting and sustainable impact on this epidemic. And that's to look more at the prevention and the recovery ends of our plan, and making sure, number one, that we're doing primary prevention, because ultimately, we need to go upstream. We really need to go further upstream to have an impact on youth and others in the community making healthy decisions and the ability to impact that. And then when people get into recovery, are the supports there to sustain them? Do they have opportunities for employment, housing, social connections, all the things that we know that are critical to sustaining recovery? And to broaden our efforts, not only to save lives, but to work on those outer edges of the epidemic.
I would just add that I came to Brown in '94 to work on the HIV epidemic, and I'm getting this sense of deja vu over and over again. This is a very complex problem. If this was simply a medical problem and we could just give some treatment, that it is, but it isn't. This touches all kinds of spheres. And really, to address this, we don't just need, scientists developing new medications. We don't just need clinicians giving better treatment. We don't need, public policy people making different laws. We don't need the activists. We need that and more. We need everything. We need all hands on deck. And it's a complex problem. We need the best and brightest. We're at this Brown University. We need your help. We need your help from every discipline to say, okay, how can I apply what I know about my expertise to bring to bear on this epidemic? And I think that's what we need.
Great. I'll just add that's why I think not just for this epidemic, but we are also seeing simultaneous epidemics of suicide in the United States, of diseases related to alcoholism. And that's why I think we've got to really focus, and why we have a broad, I think, understanding in the public health community that we've got to focus on these root cause issues and on the social determinants of what leads to poor health outcomes. I don't know if I don't know if we'll ever get there, but clearly there are reasons why people do drugs. There are reasons why people are in a lot of psychological pain. There are reasons for a lot of these waves of public health epidemics, and many of them are rooted in historic inequities that we have seen in many of our communities. Things, again, like poverty and racism and early childhood trauma and violence, lack of educational opportunities and vocational opportunities. And unless we get at some of those things, I think we'll see, the crisis will be over. People won't pay attention to it anymore. We'll move on to the next, whatever the next epidemic is, without ever getting kind of underneath what really is causing many of these really poor health outcomes. I apologize, but we have time for one last question, and it'll be over here.
Thank you for being here tonight. I just wanted to ask what your thoughts were on the Florida shuffle, or the corrupt, fraudulent treatment centers, and how prevalent of an issue that's become.
I'm not sure I know exactly what the Florida shuffle is, but I'm assuming that it's the kind of recruitment of individuals who have substance use disorders to go out of state for these treatment centers and have their families be thousands of dollars in debt, only to return to face the same situation that they left in the state where they came from. We are familiar with that, and we are, I'm sorry, I lost the track of the question. The Florida shuffle, and then what?
I just wanted to know how prevalent of an issue that's become.
So I don't know that we have the data that supports how prevalent an issue it is here. We certainly have anecdotal stories from families of their loved ones who have been sent off to treatment, come back, relapse, and then die. It's certainly not the outcome that anyone is looking for. We work with insurers primarily to look at what are you funding. There's a residential treatment program here. Family components are really important to the success of treatment, and if somebody's sent off to another state only to return here to a family that has not been part of a treatment process, the outcome is not going to be as successful as it could be if we engage them in treatment where they live, which is really more important. So the data in terms of how prevalent it is here, maybe Tracy knows, or Dr. Rich, but we certainly have anecdotal evidence that that effort is alive and well in this state and impacting families and individuals, unfortunately.
When your child has this disease, you're desperate, and you will mortgage your house and do whatever you have to do. And unfortunately, when you say treatment, when most politicians say treatment, they talk about treatment beds, and they think about this like magical bed that's there, and somehow somebody's going to lay in it, and then they're going to get up, and then they're going to be done with the disease. And that's not how it works. And in fact, what most people think of as treatment, go through a detox, go spend some time in a unit with it which has a bed, and then go back to your life. I would say close to 90% of the time that results in a relapse. And in this era, when there's so much contamination with fentanyl and other related drugs, that can be a death sentence. So I would say, a lot of these programs are doing more harm than good. That what you know, you're better off continuing to shoot up heroin because you won't lose your tolerance. And going to those programs are extremely dangerous.
Let me add two thoughts. So I know regulations are not popular at the federal level these days, but one of the reasons I think that we see, quite honestly, in the early part of this epidemic, we saw just the explosion of these rogue pill mills in Florida, largely for lack of regulation and oversight. And I think so regulation and oversight of these programs is particularly important, and that varies dramatically by states, by state effort. The other thing I'll say is, I think that we need to provide better curated information to parents and other caregivers about how you determine how to pick a quality treatment program. And again, I think Jody said that, you know, people are desperate, and somehow they equate spending a lot of money with high quality care, and that's clearly not the case. So we need to do a better job of educating consumers, if you will, how to pick a high quality treatment program. NIDA and other places have that on their website. And the third thing I'll say is that we need transparent reporting of unified outcomes of treatment. So like we do in other arenas in healthcare, where you as a consumer can look at apples to apples comparison in terms of treatment outcomes for programs. And we don't have that right now. So what you have is it drives me crazy when I watch CNN and I see passages in Malibu offering the cure for addiction treatment, and we have no oversight and regulation to get at those kinds of issues. So I want to thank you all for being here. Being from out of state, I want to tell you how lucky you are to have these four folks as part of your toolbox here in Rhode Island, but also kind of how they continue to lead national efforts in coming up with innovative and science-based approaches to deal with this epidemic. So thank you very much, everybody.
So thank you. This has been a fascinating and inspiring discussion about how universities and government agencies can work together to solve some of society's really challenging problems. And I would like to thank the American Academy of Arts and Sciences for the sponsorship of this important event, and of course our panelists, who were just tremendous. Thank you so much.